Thank you to the department for inviting me here, and my wife, who I understand was the reason that I'm here to present because she's on the Grand Rounds Committee. Thank you, Micah, who's late. So, disclosures, I don't have many. I've served as a consultant for a variety of pharmaceutical companies, most recently EMD Serono, for a drug that didn't make it to market, so I probably won't be consulting for them much longer. And Zelda Therapeutics, which is a medical cannabinoid cancer startup company, as well as a consultant for the U.S. Department of Justice. I won't be discussing any products from the above companies in this presentation. The ACGME competencies are pretty straightforward, and for the trainees, residents, and fellows in the audience, really recognizing presenting signs, symptoms, radiologic findings, and really the importance of the multidisciplinary management of these rare and aggressive bone malignancies. So we'll talk briefly about pediatric cancer as a whole. It's really not considered a public health menace in the way that adult cancer is. In terms of breast cancer is around 200,000 cases per year in the entire United States. All of the pediatric cancers put together make up about 12 to 13,000 cases per year in the whole United States. So really, the incidence of pediatric cancer pales in comparison to adult-type cancers. But if you look at causes of death, pediatric cancer is the second leading cause of death in children, second to traumatic injury like car accidents. If you break down pediatric cancers in terms of what we see most frequently, leukemia is the most common, followed by brain tumors, followed by lymphoma, and then the bone and soft tissue cancers that we'll be talking about today are sort of tied for third or fourth. At UCLA, though, I think most of you, especially the residents and hospitalists in this audience, recognize the difference in the incidence at this institution in terms of our new pediatric oncology cases being by far the bone and soft tissue sarcomas over all of the other pediatric malignancies. So a successful outcome for pediatric cancer and our bone and soft tissue cancers here really begins with all of you in the audience. Children present first to their primary healthcare providers or the emergency department. You must know the presenting signs and symptoms of bone malignancies in order to properly identify and manage these patients. And really recognizing these patients quickly, I think, is really critical to the management of these patients long term. And with sort of the increasing recognition, combination therapy, cooperative clinical trials that we all participate in, the outcomes for bone and soft tissue cancers and pediatric cancers as a whole has gotten close to 80% now. So I'm going to present a few cases to ground you, and these are patients. This one is presented a while back and has passed away years ago, and a very recent patient. This is a 17-year-old who presented with knee pain. He was a pitcher throwing a 90+ mile an hour fastball, being scouted by the minor leagues in his senior year of high school with a full ride to a renowned baseball college. And he started having pain about 6 months into his senior year that he'd been complaining of from the beginning of the year after he'd gotten hit by a line drive right up the middle. This pain became progressive. It was severe, waking him from sleep. He was getting minimal relief from ibuprofen and other NSAIDs, and then he started noticing a firm area of swelling above his right knee. And I just put these red flags here because these are things that you should know in the audience for things that need to trigger further workup. So after you do a careful history and physical, plain x-rays are your best friend. There is so much that you can get from a regular old radiograph, even in this age of complex imaging. And so this is the audience response component of the talk, and we're going to do it the old-fashioned way by raising hands. And this is a patient with an aggressive malignancy. Which of the following four, A, B, C, or D, do you think is the diagnosis here? So show of hands, who thinks it's A? We've got a couple. How about B? Everybody raise your hand. There's no penalty. B, we've got a bunch. C, none. And D, 1. So most of you remarked that B was probably what you thought. Hopefully the orthopedic surgeons in the audience or the radiologists in the audience said that correctly it was A, which is osteosarcoma. B was a benign bone tumor, very common, a non-ossifying fibroma. And why is this benign? Because of the sclerotic edges here and the intact periosteum. It's a large lesion. It looks aggressive, but in fact it's benign. C is an osteoid osteoma. This is for the pediatric boards, a small nidus with an area of cortical thickness here, and the pain can be quite severe, waking you from sleep, but is often relieved by NSAIDs. And that'll be if you get that on your boards, you should get that correct. Think of osteoid osteoma. And lastly is this little fight coming off here is an osteochondroma. So why is this osteosarcoma? This is the Codman's triangle, or the lifting of the periosteum, and we'll look at that shortly. So the classical radiographic features of osteosarcoma: aggressive periosteal reaction. That's really a hallmark of any aggressive or malignant lesion. Soft tissue extension, the Codman's triangle that we talked about, which is here. The sunburst appearance, which is all of this sort of malignant osteoid and calcification, and this permeative sort of moth-eaten appearance. The second case is a patient that presented a few months ago. This is a 13-year-old male who presents with severe thigh pain, a soft tissue upper thigh mass. He is also complaining of occasional low-grade fevers and night sweats. And on lab evaluation, you also note he has an elevated sed-rate and an elevated alkaline phosphatase. And this is his plain imaging here, which shows periosteal reaction, soft tissue extension, a fairly large lesion that goes along most of the length of the diaphysis of the femur. So knowing the differential diagnosis of bone tumors in children is a lot about location. And to use the old mantra, location, location, location is important in terms of figuring out a differential. In terms of the malignant primaries, osteosarcoma, which is really a metaphyseal type of tumor. Ewing sarcoma in long bones we think of as a diaphyseal tumor. We also can have chondrosarcoma. Lymphoma, leukemia can be anywhere. Giant cell tumor of bone, which can be both a malignant or a benign process. And then metastatic disease, neuroblastoma, rhabdomyosarcoma can show up in both diaphysis and metaphyseal lesions as well. In terms of benign lesions, osteomyelitis, which can often look like an aggressive bone lesion. We saw a picture of non-ossifying fibroma, other things like fibrous dysplasia and chondroma. We often see Langerhans cell histiocytosis, and that can be sort of on the spectrum between benign and malignant. So the second case was a case of Ewing sarcoma, and this is a diagnosis that frequently presents both in the diaphyses of long bones, as in our patient, or in flat bones of the pelvis, ribs, or scapula, and those are shown here. This is a chest wall Ewing sarcoma. This is a scapular Ewing sarcoma here, and this is a pelvic Ewing sarcoma. We also can see the Codman's triangle and this finding called onion skin or onion skinning, the appearance of the periosteum being sequentially lifted off of the expanded off of the cortex, and that's this finding that you see right here. And then we'll often see with Ewing sarcoma a very large soft tissue mass, especially with the pelvic Ewing sarcoma. So what's next? For any of these bone tumors, we're likely going on to biopsy, especially for aggressive lesions. This is where it's critical to be managed in a center that knows what they're doing, in a multidisciplinary musculoskeletal sarcoma center like UCLA. Historically, the gold standard for biopsy has been an open biopsy. And just to show you why it's so important to do this correctly, the right way to do this is to make a transverse incision, a longitudinal excision here, and an area where the small piece of tumor is removed. This is important because the incision area is going to be excised at later surgery, especially if it's malignant. This is what you don't do, this transverse incision, because you're violating multiple tissue planes, the potential for tumor contamination, and a difficulty in excising this area. This sometimes involves an amputation later on if we get these patients with a large transverse incision. At UCLA, we've pioneered what's called image-guided percutaneous core needle biopsy. We've been doing this for decades now, and this involves putting a core needle into the tumor and taking out sequential cores of tumor or abnormal bone or soft tissue. And this has been a controversy because of the theoretical potential for spread of cancer along different tissue planes and inadequate tissue for diagnosis. And I think finally we've put this we think we've put this to bed. We've done this both in children and adults. We looked at 130 cases we had done over the last decade. This was published a couple of years back. Most patients were adolescents. And in general, this was extremely well tolerated, with most of the patients getting either local anesthesia or moderate anesthesia, and having over a 90% success rate in diagnosing cancerous lesions of bone and soft tissue. For the non-cancerous lesions, it's not as effective, and I think that also reflects, open biopsy may not always give us a diagnosis either. And what I think is important is, as we enter an age of cytogenetic testing and the importance of that testing, the core biopsy samples are sufficient to get all the cytogenetic tests that we need. So our first case, the radiology was consistent with osteosarcoma, and the pathology is consistent with osteosarcoma. And although it's one diagnosis, it really reflects a variety of underlying histologic diagnoses. This case happened to be an osteoblastic osteosarcoma, and you see that here with these plump osteoblasts, malignant osteoid that's infiltrating. But you can also have telangiectatic osteosarcoma with large sort of telangiectatic areas here, chondroblastic osteosarcoma, which are chondroblasts, a predominance of chondroblasts infiltrating normal bone, and fibroblastic osteosarcoma, and a variety of other histologies. But all of these really involve the presence of malignant osteoid and infiltration of normal bone, and that's what defines osteosarcoma. Ewing sarcoma looks entirely different. And this is one of these small round blue cell tumors of childhood. The other ones that you know well, leukemia, lymphoma, neuroblastoma, sometimes rhabdomyosarcoma, Wilms tumor. You need to know those diagnoses for your board exams, the trainees here. And this really is a diagnosis that historically was made on appearance, being small round blue cells, on immunohistochemistry, looking for things like CD99, vimentin, neurospecific enolase, ruling out leukemia and lymphoma. But really now we rely on FISH, on fluorescence in situ hybridization and cytogenetic testing, to tell us that the gene that is responsible for this disease is actually rearranged. And so we use what's called a break-apart probe for chromosome 22, and when 22 separates to form a fusion protein, we see these split signals that you're seeing in this diagram, which is here. Where did our mouse go? These are the split signals. The epidemiology of osteosarcoma and Ewing sarcoma is similar in that it affects predominantly adolescents and young adults in the second decade of life. Osteosarcoma, though, has two peaks. We see one in the second decade, and we see another one later on in the 70s and 80s, which we think really is related to Paget disease of bone, causing a secondary type of osteosarcoma. If you separate out the adolescents, women or young girls present at the age of their sort of puberty growth spurt around 12 years old, and the boys present a little bit later, 14 to 16. But again, we see patients presenting from age 2 to age 90. Ewing sarcoma versus osteosarcoma in terms of the locations. Osteosarcoma in red here is a metaphyseal lesion. So most commonly we see it around the knee, and the distal femur is the most common location. The proximal tibia, the proximal femur, and the proximal humerus are common locations that we see, but by and large we're seeing tumors around the knee. Ewing sarcoma, again, a diaphyseal lesion of long bones, so commonly in the diaphysis of the femur and the humerus, but also the flat bones of the pelvis, the chest wall, the ribs, and scapula and clavicle. And that's Ewing sarcoma. It has only a single peak in adolescence. Our initial staging workup for this disease revolves first around plain films of the primary that we've already done, a thoracic CT because that's the most common presentation of metastatic disease. So 20% of our patients with both Ewing's and osteosarcoma will present with thoracic metastatic disease. An MRI of the primary lesion, which tells us much more accurately the extent of disease and, importantly, for the extent of surgical resection. The gold standard for looking for osseous metastatic disease, so bone mets, which are the second most common area of metastatic disease for both Ewing and osteosarcoma, has really been the gold standard, and this is what it looks like. You just get a lot of activity in the area of the tumor. This is normal bone marrow activity in the pelvis and in the proximal humeri and manubrium. But more commonly, we're using FDG PET-CT here, and we've been one of the centers that has really pioneered this for all cancers, but including bone and soft tissue sarcomas. We do bone marrow biopsy in Ewing sarcoma because it has a potential for spread to bone marrow, but I believe that in the next decade, as we have better imaging, more accurate imaging modalities, we may do away with bone marrow biopsy as a staging evaluation. And this is work that we've done at UCLA. As I said, that bone scan has really been the gold standard, but the false negative rate is quite high. So these are two patients as examples. This was read as a normal bone scan in a patient with osteosarcoma. You can see the small area of activity here. This was called normal degenerative disc degeneration. But if you look at the PET-CT scan, there's quite a lot of activity here. We biopsied this, and it was positive for osteosarcoma. So the PET was read as abnormal, and the bone scan was read as normal. This is a different patient who had a completely normal bone scan. This patient had a limb salvage procedure here, so you can't quite see the leg. But we often see activity in the contralateral knee due to stress. And this patient was having a lot of pain. We got a PET-CT as well. It showed this very high area of activity. We biopsy it, and this was also osteosarcoma. So looking back at these retrospectively, we found that PET-CT is much more sensitive and specific. In fact, it's 100% sensitive and specific for detecting bone and soft tissue metastases from bone sarcomas. A little bit of history, because I'm kind of a history buff. Bone sarcoma has been around forever, and they probably are in the fossil record in dinosaurs, although that's harder to prove. The oldest human that's been found to have an osteosarcoma was just reported a couple of months ago. This was a caveman from South Africa 1.7 million years ago. And this is the osteosarcoma, we believe osteosarcoma lesion here. This is a Egyptian mummy that was unearthed from the Giza pyramids. But really the modern era of sarcoma started in the 1800s with John Abernathy, who was an English surgeon, who is actually best known for some digestive tablet that he invented, but in fact coined the term sarcoma from Greek, which means fleshy excrescence. And this is James Ewing, who gave the eponym to Ewing sarcoma, actually was given to him by somebody else, but he's actually best known for starting Memorial Sloan Kettering Cancer Center, really the modern paradigm for the comprehensive cancer center today. So the history of surgery in Ewing and osteosarcoma was quite dire prior to the late 1970s. And Sir Stanford Cade, I think, says it best at a meeting of orthopedic and surgical oncologists at the Royal Edinburgh. He says, "Gentlemen, if we operate, they die. If we don't operate, they die. This meeting should be concluded with prayer." That was the state of surgery and the treatment of this disease. And that is, if you had a tumor in the ankle, you cut here. If you had a tumor in the proximal tibia, you cut above the knee. If you had a tumor just above the knee, you cut here, and if you had a tumor in the proximal femur, you cut at the hip. Despite these aggressive and disfiguring operations, the survival for these patients was 10%. But 1974 was an important year. It was a year that Nixon resigned, that Mikhail Baryshnikov defected to the United States from Russia, that Hank Aaron hit his 715th home run, breaking Babe Ruth's home run record, and one of my favorite movies came out, Blazing Saddles. And Gene Wilder just passed away a week ago. But more importantly, this was the era of chemotherapy in malignant bone tumors. So in osteosarcoma, 2 simultaneous publications in the New England Journal of Medicine, one by Cortez's group and the other by Norman Jaffe's group at Dana-Farber, at Sidney Farber at the time, one using adriamycin or doxorubicin in osteosarcoma, and another using high-dose methotrexate with what we know now as leucovorin factor or citravorin factor. And both of these papers showed an improvement in survival or in delaying gross metastases for these patients, because despite amputations, these patients almost all died of pulmonary metastatic disease. And this really heralded the improvement of our survival and the development of better surgeries over time with the ability to save these patients or delay their death. So that prior to 1970, 100% of patients had amputation, 10% survive, and now we are doing amputations on roughly 10% of our patients, and our survival is up to 70%. So this is the age of starting chemotherapy, and as you can see, the survival rates improved dramatically. This led to the second randomized clinical trial for osteosarcoma, and this was done at UCLA by Dr. Eiler and Dr. Eckhart, who's here today. This was one of the seminal trials in osteosarcoma, and this trial was actually stopped early because of an improvement in survival of the patients that got chemotherapy. The regimen of chemotherapy and treatment is much different than we use today, but the principles of treatment were similar. So what have we learned over the years for these patients with Ewing sarcoma and osteosarcoma? Number one, we've learned that response to chemotherapy dictates the outcome. So after we give 2 to 3 months of chemotherapy and we remove these tumors, we look at the tumors under the microscope. If over 90% of the tumors are dead, in general, patients are going to do better. And if less than 90% of the tumor is dead under the microscope, you're going to do poorly. And this is something that has been shown over the years, especially with osteosarcoma, a little less so with Ewing sarcoma. But being a pediatric oncologist is sort of like doing the laundry. So in general, you can put more and more soap and your laundry will get cleaner, but at some point the machine is going to get overwhelmed and soap's going to start pouring out, and that's why I'm not allowed to do the laundry at home. So more chemo is not always better. In Ewing sarcoma, maybe it is. So a seminal trial that was done in 2003 by Holcomb Greer and the Children's Oncology Group showed that if you added 2 agents, ifosfamide and etoposide, an alkylating agent and a topoisomerase inhibitor, to a standard regimen of vincristine, doxorubicin, and cyclophosphamide, that in fact the outcomes increased significantly from around 50% to around 70% event-free survival. If you look down here, these are the patients with metastatic disease that no matter what you did not improve, whether you gave them intensified therapy or not. More recently, in the Children's Oncology Group, in the AEWS 0031 trial, we gave even more chemotherapy, but the way that we did this was to intensify the regimen in what's called interval compression. So we give chemotherapy every 3 weeks, and we do that because it takes roughly 3 weeks for the blood counts to recover, and that's what dictates our next cycle of treatment. Now with the modern use of growth factor stimulators like filgrastim or pegfilgrastim, we're able to give the chemotherapy in much tighter intervals. And so that was what was tested here, and lo and behold, the improvement in survival went from roughly 67% to 77% event-free survival in the intensive arm. So more is better in Ewing sarcoma. Not necessarily true in osteosarcoma. So our standard regimen in osteosarcoma is methotrexate, adriamycin, and cisplatin, this what we call the MAP regimen. We know that poor responders to treatment up front, to MAP therapy up front, do poorly, so why not intensify the therapy for these patients that we know are going to have a bad outcome? So in this randomized international trial, we randomized almost 620 patients either to get standard therapy, the MAP therapy, or MAP plus 2 other agents used in Ewing sarcoma, ifosfamide and etoposide. And in fact, no difference in overall survival, but a lot more toxicity, as you would expect from having a more intensive regimen with the addition of 2 new agents. So the standard of care now, still over the last 40 years, the same drugs we've been using since the early 1980s. Sad. In the modern era now, our combination multimodality therapy includes what we call neoadjuvant chemotherapy. That means we give the drugs prior to surgery, a local control surgery for osteosarcoma. In Ewing sarcoma, we often use radiation therapy in conjunction with surgery or instead of surgery. And that's because radiation is more effective for Ewing sarcoma than osteosarcoma. And then we proceed with a long regimen afterwards that we call adjuvant chemotherapy for the non-oncologists in the audience. And so this is a typical regimen for osteosarcoma where weeks go by and we're giving usually inpatient adriamycin and cisplatin, high-dose methotrexate back-to-back. And the residents and hospitalists here who've taken care of all of our patients know these regimens, I think, by heart now. They're probably some of the best sarcomatologists in the country at Santa Monica. Thank you guys that are listening at Santa Monica. Ewing sarcoma, similar regimen. Drugs are different. Again, we're giving drugs every 2 weeks, mostly in the hospital, surgery after this period of neoadjuvant therapy, and then roughly 20 weeks or so of adjuvant chemotherapy afterwards. And this is what our regimens look like so you all know that take care of our patients. So as we've sort of chemotherapy paved the way for better surgery, that allowed the surgical oncologists and the orthopedic oncologists to develop better surgical tricks to deal with this disease, so that no longer did we need to do amputation. And this really heralded what I consider the dawn of limb salvage, which started in the early 1970s through the mid-80s. And this was really taking place over the course of a decade, so that in 1985, this Cancer Treatment Symposia came out that was worked on by Dr. Frank Sim at the Mayo, Dr. Jeff Eckhart, who's here at UCLA in the chair of orthopedic surgery, and the entire pediatric oncology group to really come up with guidelines for limb salvage and chemotherapy. So the principles of limb salvage, so you all understand, are pretty easy. In sort of scope. You're just cutting the tumor out with some area of normal tissue above and below. You're replacing it with either a metallic endoprosthetic or a cadaveric allograft. And here we've done more, we've favored metallic endoprosthetics. And this is the patient that I presented. This is the second patient with Ewing sarcoma. He basically had a Ewing sarcoma of the entire femur, and there wasn't enough margin to take all up the top here, so he had what's called a total femoral replacement. And that's what the endoprosthetic looks like. That's his abnormal bone that's removed, and that's what it looks like now, a completely functional leg. But we tell these patients that they can't run, they can't jump, they can't play sports, definitely no contact sports, and really it's a functional leg, but one that we treat with a lot of care, but the kids do what they want. So post-op at 1 year, this is one of our star patients. She's doing full extension and flexion. Post-op at 2 years, we've told her no running or jumping, but she figures rock climbing is fine and texts me this picture. And post-op 3 years, now she's jumping off of cliffs. And this is why my blood pressure is so high. So what have we learned about limb salvage? Well, we believe it improves function, although it's debatable. There's a higher complication rate, that is for sure. The questions that we are answering now, does it improve the quality of life? We believe it does. Does it improve the psychosocial outcome? We believe it does. And does it increase the risk of local recurrence? It doesn't appear to really increase the risk of local recurrence when done correctly over an amputation. In the skeletally immature, endoprosthetic replacement limb salvage is much more challenging. And this is the era of the expandable endoprosthesis. But it is really a challenge, and in the words of Dr. Salter, you need to be sure what you're doing to the patient, you're doing for the patient. So just to know, physeal closure happens at 14 in females, at 16 in males. Most of the growth potential is happening around the knee, where most of these tumors are going to be, at least in osteosarcoma. And the lengthening procedures, until recently, were not small operations, and they still can be big operations. So this is Dr. Eckhart with one of his patients in 1990, and this is 21 years later in 2011, and you can see, well, either Dr. Eckhart shrunk a lot, which I think is possible, but he definitely grew. And this is, I think, 5 or 6 lengthening procedures later with a capsulectomy to really carve out this endoprosthetic gets quite scarred in, and then modular replacement. There are complications with expandable prostheses. They can cause collapse and debris. Especially for the younger patients that can't keep up with the physical therapy, they can't quite push it, they can develop flexion contractures. This is a patient of mine who insisted on playing competitive soccer, and he had a fatigue fracture and fractured the stem of this endoprosthetic. And then you can have stem loosening, which is really a failure of the cement. Endoprostheses, metallic endoprostheses, are just not as strong as normal bone, believe it or not. Another issue that has not been as much of an issue here at UCLA has been endoprosthetic infections, but I could tell you if you get one of these, the amputation rate is high. It's just hard to salvage contaminated components. And in the future, now and in the future, really the emphasis for the skeletally immature patients is non-invasive or minimally invasive extendable prostheses. This is the Stanmore implant, which has a motor, a gear motor on the inside, and with a rotating magnet extends the prosthesis over time, so you can extend it 1 millimeter over 4 minutes. It seems painful, but it really is not. There's no need for an inpatient hospitalization. There's no sedation required. And in fact, if you overdo it, you can reverse the amount of extension. But I think we shouldn't forget that amputation still has its role. The prosthetic improvements that largely have happened by fighting a whole bunch of wars in the Middle East have really enhanced the functional results of our patients. And sometimes an amputation is the best surgery for these patients. This is a patient of mine who plays competitive football, or was playing competitive football with a below knee amputation, a lacrosse player, a patient with an above knee amputation doing rock climbing, and this is one of my patients now who has this $70,000 prosthesis that he snowboards on, that he plugs in at night. So the next set of challenges to tackle. This is my patient playing football who had a below knee amputation. He actually had a deep venous thrombosis, was on an anticoagulant, and 1 week after finishing chemotherapy forged a note from me to the coach to say that he could play football. I found out because somebody else forwarded me a picture of him on the front page of the sports section of his local newspaper, that he had gone back to his team 1 week after chemo, and that his doctor signed off on it. And anyway, this is the adolescent, young adult group of patients. They sort of do what they want. Anyway, we had a chat about that. But really, aside from that, surviving sarcomas is a rocky road. We need to remember, of the patients that we cure, 90% of them will have chronic medical condition by age 50. 80% of those patients will have a serious or disable or even fatal chronic medical condition. And we've affected with our therapeutics almost every physiologic system. And the risks are not normalizing with time. one of the worst possible things that our patients can get are secondary malignancies that they get from the anthracyclines and alkylating agents, especially the alkylating agents that we give, and radiation for Ewing sarcoma, so that at 20 and 30 years out from diagnosis, Ewing sarcoma patients have over 20% chance of having a secondary cancer. The leukemias that they can get from the alkylating agents and topoisomerase inhibitors are almost invariably fatal for these patients. And we've had a couple of those patients, one that survived and one that's passed away. This is really, truly where we have missed the mark, and that's the survival for patients with metastatic Ewing sarcoma and osteosarcoma, refractory disease and recurrent disease, despite millions and millions of dollars of money invested in clinical trial and new investigational agents, the thousands and thousands of patients put on trials. We're still just as bad as we were 20 and 30 years ago, so that roughly 20% of patients are surviving with metastatic recurrent and refractory Ewing sarcoma. And this really brings us to the cancer moonshot, which we're faced with now, charged by the president, and this idea of cancer precision medicine. And this is what we've been doing. These large clinical trials where we may try a new investigational agent or a new alternative to treatment, and by and large, most patients will not benefit. Some patients will benefit, and some patients will have serious adverse events. What we're moving to, as we still do these clinical trials, are trials that really involve targeted cancer genetic problems that are individualized for patients, and this sort of N of 1 clinical trial. Before we do that, in these bone tumors, we need to really understand the molecular pathogenesis, and they're quite different. Osteosarcoma is highly complex with unbalanced karyotypes, genetic gains and losses, chromosomal instability, and telomere dysfunction. This is a Sarcos genetic plot showing that. And Ewing sarcoma, which is quite simple actually, it has one fusion gene, usually a translocation of chromosome 11 and 22 that creates an aberrant chimeric transcription factor and results in transcriptional deregulation. And this is very simply put together in this slide. EWS and FLY1, which are 11 and 22, come together. They bind to RNA helicase and Pol2 and drive aberrant transcription. There are other chromosomal translocations in Ewing sarcoma tumors. Usually it's EWS-FLY, the 1122 translocation, but it's quite a EWS is quite a promiscuous gene and can partner with all sorts of other things. So if we could just target the EWS-FLY mutation or protein fusion, then perhaps we can have an effect in this tumor. I mean, that's really the precise way of doing it. Just like targeting BCR-ABL has changed the outcome in chronic myeloid leukemia, perhaps we can do this in Ewing sarcoma. This is work that has been really pioneered by Jeff Turetsky at Nationwide, and has been purchased by Internal Therapeutics, which has developed it even further, where there is a small molecule that prevents EWS-FLY from binding to RNA helicase, thereby stalling the abnormal transcriptional and malignant transformation process. And we see that here EWS-FLY activity has been knocked down, and in rat orthotopic xenograft models, using different iterations of this molecule actually cause complete tumor regression. So that brings us to the first in human clinical trial of this small molecule, TK216, which is sponsored by Internal Therapeutics and funded by a foundation, the Slifka Foundation, and is being conducted now at UCLA, MD Anderson, and Sloan Kettering. We've enrolled the first patient here who's upstairs, and this is his 4th day of treatment, and I'm happy to report that he's still alive and had no toxicity. But again, first in human, so we weren't really sure what to expect. If you look at Ewing sarcoma and osteosarcoma, even though in Ewing sarcoma you have that one translocation, we see a lot of other kinase pathway irregularities, so we see dysregulation of a variety of motifs, and no grand rounds talk would be complete without one Western blot, and I think I have 2 or 3, and we'll leave it at that. And so we've been interested in the Denny lab. This was work that was done by Jenny Anderson, who got so jazzed about Ewing sarcoma that she decided that after a graduate PhD degree and postdoc in her lab, that she would go on to medical school. So, so this is work that Jenny did, and so we've shown here that phospho-AKT is quite upregulated across a panel of Ewing sarcoma cell lines and osteosarcoma cell lines. This is rhabdomyosarcoma that we're interested in as well. And that if we give a PI3 kinase inhibitor, which hits AKT downstream, that we can shut down phospho-AKT, and we can also inhibit proliferation of both osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma that we're not going to talk about. And so we're quite excited about that. And we've also shown that, I think one of the things, and I don't show the slide here, that if you look at phospho-AKT expression, as time goes on, it turns on again. So in about between 6 and 24 hours, phospho-AKT expression goes from off to on. And we believe that that's from escape pathways. So theoretically, targeting more than one pathway that has an escape through PI3 kinase or AKT by targeting MEK with trametinib, or mTOR with sirolimus or everolimus, or hitting it from above with an IGF-1R, insulin growth factor receptor monoclonal antibody, or small molecule inhibitor, that we can have a synergistic a response. And we've done that with a MEK inhibitor being trametinib, with a PTEN inhibitor, or an mTOR inhibitor being rapamycin, and with an IGFR inhibitor, which is a Novartis compound, showing synergistic cytotoxicity in these cell lines. So something a little bit different. This is back to the precision medicine model. I mean, really the way that we're treating these patients when they have, especially recurrence of disease, we are picking a salvage regimen off the cuff that we think is going to be most effective for them. We are really doing this empirically, and we only know if it's working if after 2 or 3 cycles and we re-image them that the tumor has shrunk. It's really not a precise way of doing cancer chemotherapy, or anything for that matter. Ideally, what we should be doing is taking these tumors out when we diagnose that they've recurred, or biopsying them, doing next-generation sequencing to identify what the irregularities are in their signaling, doing phosphoproteomic analysis as well, trying to figure out, interrogate this data to see if there are available clinical trials or therapeutics that will target these abnormal pathways, while doing an animal model and testing available agents and experimental agents in an animal model. A lot to do, but I think this is really where we're headed. And we've been doing this here. This is work that's been pioneered by Dr. Eilber, and actually a private company here at UCLA. And this is a patient with Ewing sarcoma, whose tumor, with a rare form of Ewing sarcoma, rare genetic variant, whose tumor was implanted in a mouse. We tested 2 experimental agents, palbociclib and lincitinib, which is an IGFR inhibitor, and showed that both of these had efficacy. And this is exciting because both of these are available in clinical trials, so it would actually help us make educated decisions of these 20 clinical trials, which would be potentially most efficacious for this patient. And this slide is just to show here that, in fact, the phenotype of these tumors between implanted, the xenograft, and the primary is basically the same. This is one of my patients. She recurred in her lung not even 6 months from the completion of treatment. This is a poor prognosis. Recurrence is poor prognosis, but this is even worse. This patient had her tumor resected by Dr. Yanagawa, who's here, and then implanted in a mouse. And then we treated not just with standard salvage, being ifosfamide in the yellow, and gemcitabine and docetaxel in the red, but also with other agents that are off-label, sorafenib, which is a multi-receptor tyrosine kinase inhibitor, and everolimus, which is an mTOR inhibitor. So, you know, at least what we've shown here is that although we started her on ifosfamide, gemcitabine and docetaxel seem to be the most efficacious. And so we've completed her ifosfamide treatment, and now if she further recurs, we would do gemcitabine and docetaxel next. So no cancer talk would be complete without a couple slides on immunotherapy. We are in the renaissance phase now. The therapies for melanoma and lung cancer have exploded in terms of actually having real durable survival for these patients. But I think it's important to remember that this field started in bone cancer. This started in osteosarcoma in the 1890s by a guy named William Coley. And everybody heard of Coley's toxins. What he would do is he would inject streptococcus and later streptococcus killed bacteria into patients to generate a massive immune response. These patients would feel horrible. They'd have fever to 105. But he felt, and it was reported that this was actually curing some of these refractory patients. That fell out of favor in the 40s and 50s, but at least really had spurred the idea that it wasn't infection, but in fact an activation of the immune system that was causing the remission of these tumors. Now we understand things to be a little bit different, and so we recognize that cancer cells actually can express certain receptors like PD-L1 that actually cause T cells to be in a suppressed state and not activated. And so this T cells cannot recognize cancer cells as foreign and won't activate the immune system with antigen-presenting cells. We've looked at PD-1 and PD-L1 expression in osteosarcoma and Ewing sarcoma. I think it's important to note that in general we believe that if you don't have PD-1 and PD-L1 expression in your tumors, you're not going to respond as well or at all to these new checkpoint, what we call checkpoint inhibitors. And that's certainly something that's been seen in melanoma and lung cancer. So looking at, these are Ewing sarcoma patient samples. We looked at 30 of them in Ewing sarcoma and 40 in osteosarcoma. And what you'll see is that a certain subset in the localized tumors, that's patients with tumor in one area, versus those that were metastatic, and these were all metastatic to lung, actually had a predominance of PD-1 and PD-L1 expression. And then localization as well, co-localization of CD8, which is an immune marker, obviously, for the CD8 T cell. In osteosarcoma, it's a similar thing, but there's much more and more robust PD-1 and PD-L1 expression and co-localization, and these are just representative pictures here that show the PD-L1 expression in tumor cells and the CD8 infiltration. Why is this important? Well, I think it gives us, and now we have 2 clinical trials with the PD-1 inhibitor in osteosarcoma and Ewing sarcoma. But it sort of heralds the idea of this, is this really precision medicine that we're doing? So this is a patient that had another bone tumor called a malignant chordoma. This is a patient that had a primary in the clivus, which I had to check my anatomy book to where the clivus was, but it's back here somewhere. And so we saw on the molecular profiling that there was strong expression of PD-1 and PD-L1. So I took this patient and put him on a patient access protocol for the PD-1 inhibitor nivolumab, and this is going to be presented in a couple months by one of our fellows, Dr. Jonas. We started this PD-1 inhibitor in February of this year. These are the tumors. He had tumors in his lung and on the chest wall, and there was one up here as well. Within 2 weeks, so we gave 1 dose, you can see the tumor shrinking. This is a patient that's progressed on numerous lines of chemotherapy. In 1 month, the tumors are almost gone. What we see here, though, is a mixed response. So, in fact, he had this tumor that was close to the axilla started to grow while the other ones almost disappeared. In 3 months, they still were almost gone, but this one continued to grow slightly, and we actually focally radiated that tumor because it was causing him pain. A couple weeks later, checking his labs, we recognized that he had a massive thyroiditis. And we now know that with these immunotherapies and checkpoint inhibitors, this is one of the main dose-limiting toxicities of these agents, that we're getting really autoimmune phenomena. So his T3 was 780, his TSH didn't even register. And so at that point I felt that we had to steroid pulse him. And we can debate whether I did the right thing or not, but we did pulse him with steroids, and within a few months the tumors grew back to their original size. We stopped the nivolumab and put him on another clinical trial. So this is what we really don't understand about some of the precision medicine here is we have these new agents, we just don't know what all the dose-limiting toxicities are. So quickly, conclusions. I think successful recognition and initial management by our primary healthcare providers are critical. Chemotherapy and surgery have evolved together to improve our survival and outcomes. We continue to fail in the treatment of metastatic and recurrent disease. The development of new therapeutics is really critical and important, and we think that precision medicine is really the way that we're headed. Finally, multidisciplinary management at a major sarcoma center is the key to success, so please call me or any of us if you have a patient with a bone tumor. This is the good-looking group of people here, but it's only half of us. The other half didn't show up to picture day. I just want to highlight Dr. Eckhart, who's the chair of orthopedic oncology, Dr. Eilber, Dr. Fred Eilber, his son Fritz. These two started the sarcoma program 40 years ago. These are the busiest sarcoma centers in the United States. Us, Sloan Kettering, and MD Anderson. Lots of stuff we didn't talk about, but you can invite me back maybe next year. And these are the thank yous. A huge thank you to the nurses, residents, and hospitalists at Santa Monica, where we moved our program 4 years ago and have done a stellar job taking care of our patients. Margie, who's the sarcoma nurse manager and helps me keep everything together and in one piece. Our research team, the Pennington Family Foundation. These three important people. Dr. Jeff Eckhart, who's the chair of orthopedics, has, despite my political differences with him, is a father figure to me and a mentor. Dr. Chris Denny, who's been my mentor since I was a first-year fellow and is a sounding board. Dr. Judy Gasson, who instilled the goal of creating this program when I was a first-year fellow and basically gave me the reins to do it. My wife, who's here and is a terrific doctor, and I think the best doctor, but she's an even better mother and is always telling us to be quiet both here in the hospital and at home. And then a special thanks to the patients that are survivors that let me know sort of every week and every month how they're doing and how grateful they are, inviting me to their graduations and their weddings and their baby showers, not always in that order. And then the inspiration that this talk really comes from, and those are all of the hundreds of patients over the last decade that I've watched pass away from this disease who really inspire me to come to work every day and to make a difference. Thank you.